So we'll move on to liver resection. We've already introduced the idea of ablation. We've already introduced the idea of radiosurgery. So now I just wanted to talk a little bit about the surgical approaches to the liver. This is one area where we do have good evidence. In fact, we now have studies with 10-year follow-up. This is a manuscript from Dr. Tomlinson where he talks about 10-year follow-up in patients who've had resection of colorectal liver metastases with follow-up in 612 patients. The 10-year survival rate's about 17 to 25%. In fact, 97% of the 10-year survivors were disease-free at the last follow-up, and there was only one disease-specific death after 10 years. The problem is that our current understanding is still somewhat limited. We have lots of information about the surgical approaches and how well we do from a surgical aspect, but we have very little information about how we do from a disease perspective. There are no large randomized trials of resection versus any of the other strategies that we've talked about, either cyberknife therapy or ablative therapy. We don't have any head-to-head comparison studies that are of significant value. We do have large retrospective series, mostly from single institutions or combination of several institutions that have documented 5-year survival rates that vary anywhere from 30 to 60% in patients that are undergoing resection for colorectal liver metastases. Of those studies, what we've learned is that detectable residual disease is the single most important negative prognostic factor. So what's important is that we can resect the disease with negative margins. The other things that are important are probably multiplicity of tumors, bilaterality of tumors, the size of the tumor, and preoperative CEA. Although these are important, they don't preclude a resection in a large number of patients. This was one of the first sort of landmark studies that looked at some of the prognostic factors. This is from Yuman Fong at Sloan Kettering. And the factors that he looked at from large prospective databases was node positivity, disease-free interval of less than 1 year, more than one hepatic tumor, the largest tumor being of significant size, defined as greater than 5 centimeters, and a high preoperative CEA level. And you got 1 point for each of those factors. And what he did was look at survival based on your overall score. And essentially what you saw was that anybody above the score of Yuman Fong's score of 5 had essentially a 0% 5-year survival. And you can see that how the higher the number of, your score, the lower the median survival. Since that time, really, this Fong criteria hasn't been used as extensively because we've relied on more advanced nomograms, and we've also expanded our definition of who's resectable. And in 2006, the SSO and the AHPBA met to form a consensus opinion on who would be resectable in regard to colorectal liver metastasis. And basically, the most important is that you have to get a negative margin. And so a positive margin should be avoided. But basically, the big impact was that what we decided was that as long as you can save 2 contiguous liver segments, which roughly equates to about 20% of the liver volume in a healthy liver, you can preserve the inflow and the outflow. Obviously, you have to have blood supply in and blood supply out, as well as biliary drainage. Then as long as you can fulfill these criteria, the patient would be a candidate for liver resection. So the old criteria was that they had to be an acceptable medical candidate, and there are some negatives or positive prognostic features. Less than 4 lesions, no extrahepatic disease, you could get a negative margin, single lobar disease, and lack of progression on chemotherapy. That's changed. And now, basically, as long as they're an acceptable medical candidate, you can get an R0 resection, and you can save 20% of the liver volume, or 2 contiguous liver segments with adequate inflow and outflow. The patients are now considered to be an adequate surgical candidate for liver resection. So what does it mean when we talk about 2 liver segments? This is going back to medical school days for many of us, but the liver is separated into 8 segments. Segment number 1 is the caudate lobe, which is a little posterior segment back here. But the left side of the liver, which is about 40% of the liver volume, is made up of segments 2, 3, and 4. The right side of the liver is made up of segments 5, 6, 7, and 8. The gallbladder sits about at segment 5. This is Couinard's classification. And if you look at the pedicles, The right pedicle gives off the branches to segments 5, 6, 7, and 8. The left pedicle gives off the branches to segments 1, 2, 3, and 4. This is an operative picture of the same thing because we had to throw in an operative picture at some point. This is the hepatic artery with a branch to the left. The right branch has already been ligated. This is the right portal vein, this is the left portal vein, and this is the common bile duct giving off branch to the right side. And you can see how we try to isolate the pedicle right before division of the liver. Some of the things that us hepatobiliary surgeons think about is that even though you would think that this would be a bad sign in most patients with either a colorectal liver metastasis or with hepatocellular carcinoma, in some ways, from a postoperative standpoint, this patient will do a lot better than this patient. And the reason for that is because this patient with the large tumor has already knocked out his portal vein. So the left side of the liver is already hypertrophied. And at the time of the surgery, the patient will essentially lose very little normal liver. This patient over here with a very tiny liver lesion has no contralateral liver hypertrophy, and they'll lose a lot of normal liver, which means that the perioperative course will be quite complicated because the patient will have much more significant complication of bleeding in the postoperative or the perioperative period. So what do we do in patients like that? Well, we rely a little bit on our interventional radiology colleagues. So this is a tumor sort of similar to that last patient where you're going to lose a lot of normal liver volume. And what we'll do is we'll do an angiogram and embolize the right portal vein. As you can see, this is the pre and post embolization images. And what that does is it sort of tricks the body into thinking that the right lobe of the liver has already been resected. And so you'll see a coincident hypertrophy of the left side of the liver, so that this side has now gone from an area this big to an area this big, and you can see that the right portal vein has been embolized here, and that'll reduce the perioperative complications, and the most significant being bleeding. The other big advances that we've been making in liver surgery is that we become more and more aggressive in our operative approaches. This is a paper. It wasn't published in 200, it was published in 2000. This is René Adam's paper from France, and this is like an illustrative example of how we do staged liver resections. So before these approaches were really popularized, this patient would have been an unresectable liver patient in regard to colorectal liver metastases. They've got bilobar disease. So this patient was downstaged with chemotherapy. They got a right hepatic lobectomy, and then the left side of the liver is allowed to hypertrophy over a 6 weeks to 2 month period of time. If you see somebody who's had a hepatic lobectomy and scan them about 2 months later, the liver volume will be essentially back to normal. And then they've gone on for a second liver resection of the left lateral segment, essentially living on segment 4 of the liver. This is really a compilation. These are very selected, highly selected studies. But if you look at the more recent studies looking at liver resection for colorectal liver metastases, the 2 points to take home is that we're quite good now with liver resections. The operative mortality is essentially 1%. Even 10, 20 years ago, the operative mortality varied anywhere from 5 to 8%. But in the more recent series, that should be the perioperative mortality rate on very highly selected patients. And 5-year survival rates approach anywhere from 30 to 60%. So some of the things that we do know is that hepatic resection is critical to long-term survival and is increasingly safe, with a mortality of approximately 1 to 2% and 5-year survival approaching 60%. The tumor burden factors do affect prognosis, so multiplicity, CEA levels, ability to achieve an R0 resection, the presence of extrahepatic disease does matter. Adjuvant chemotherapy appears to alter outcomes, so we do have studies suggest the use of systemic chemotherapy both pre and post resection. And then preoperative chemotherapy does lead to some histologic changes in the liver, so we do worry about things like steatosis and steatohepatitis. We worry about vascular changes, and the effect of these chemotherapy agents on overall survival and perioperative morbidity is still somewhat unclear. So this is our last case presentation. This is a patient of Dr. Calvo's. She's a 65-year-old female with the usual comorbidities that we see in North Carolina. In 2007, she had a T2N0M0 moderately differentiated adenocarcinoma of the colon that was resected, and the patient received no adjuvant chemotherapy. In 2009, so a disease-free interval of 2 years, she had a rising CEA level and a CT PET with uptake in the left lobe of the liver. There was 2 4-centimeter masses in the left lobe of the liver, so Ben took her to the OR and resected the left lobe of the liver, left hepatic lobectomy. The lesions were in segments 3 and 4. There was negative margins. The patient then received FOLFOX. The patient received FOLFOX pre-liver resection. And then in 2011, she was noted to have a rising CEA level to 6 and a CT PET with uptake in the right lobe of the liver. And here's the image. So what we see here is, here's the suprahepatic cava, here's the right hepatic vein, and you see about a 2-centimeter lesion that's in segment 8 of the liver. Here's an axial image, here's a coronal image. And I'll first start with Matt. What do you think you'd offer this patient?
Size is good for ablation. The number is good, 1.
Yes?
Location, bad.
So what are your concerns in regard to ablation?
Well, the lesion is so close to the right hepatic vein and cava, there'll be significant heat sink loss, and it'll be very unlikely for us to get a total tumoricidal thermal dose to that area of the tumor that's bordering those vessels. Those are decent-sized vessels.
Yeah, so the same real concern lies from a surgical approach. That area could be resected. It would be difficult, and the problem is that you'd be very hard-pressed to get a negative margin because we'd be right on the right hepatic vein. If we injured the right hepatic vein, the patient would be very shortly on a transplant list. And so those are pretty high stakes in regard to surgical resection. So I don't think that this person would be an optimal candidate for a liver resection. Joel?
So as I said earlier, we tend to get the ones that no one else wants. And indeed, because this is a real challenge for a surgical or an ablative approach, and it is something that can be treated, I think, very reasonably with a radiosurgical approach. There appears to be a reasonable amount of liver volume left. There's probably no significant pre-existing liver disease. And the fact that it's near the vessel is actually not much of a problem for us. So I think this would be a very reasonable candidate for a radiosurgical approach with the likelihood of good local control of that lesion. And the issue is obviously would then be whether there are additional lesions that show up.
So say this wasn't as close to the vessel, Matt. Is there any criteria that you use for picking radio frequency ablation versus microwave ablation versus cryotherapy?
Well, if ablation was a possibility, cryotherapy, I think, are more awkward to use in the liver, although that's where it actually began. And the complication rates from cryotherapy in the liver have been higher, usually cracking and bleeding. No clinical difference yet for the difference between radio frequency ablation and microwave ablation. So a lot of that is personal preference and what unit you happen to own at that time. But the size there, I think, is that less than 3 centimeters or so?
Yeah, it's about 2.
So that, if that were in a different location, this patient would be a candidate for that.
So it doesn't matter what you only pick, RFA versus microwave?
I'm using microwave more because it's a little shorter in time, and I think there is less, if there is a vessel next to it, wouldn't be as big as this, there's probably less heat sink with it.
What about chemotherapy-loaded beads?
Well, I think for an isolated lesion, that would not be my first choice. If you can get it with an ablation technology, particularly if it's 3 centimeters or less, where we have a greater than 90% chance to get a total tumoricidal kill of that lesion, I think it would be preferable. Now, if there were 3 or 4 now of those lesions, I think catheter-directed therapy would then be entertained.
Any other questions from the audience? Okay. I think that's it.